This episode was recorded in Q2 2026. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
Always consider future risk. So a history of an acute asthma attack is a major risk factor for future acute asthma, and salbutamol overuse is the other. Make sure to refer high-risk patients because a history of multiple asthma attacks means poor control and means very high risk. And I suppose to always view an exacerbation, it should be seen as an opportunity to discuss self-management and an asthma action plan.
Hello and a very warm welcome to the GP podcast from the Irish College of GPs with me, Dr. John Maher. Today I'm joined once again by Dr. Paul Ryan to discuss asthma management in primary care. Here's Paul.
Hello John, my name is Paul Ryan. I'm the Therapeutics lead for the Irish College of GPs. I'm a dual trained pharmacist and GP, and I work in Mayfield in Cork City.
This is part 2 of my discussion with Paul, so if you haven't had a chance to listen to part 1 yet, you might pause here and go back to part 1, which you'll find in the show feed. In today's episode, Paul picks up from last week with a discussion of the recent Asthma Joint Guideline from the British Thoracic Society, NICE and SIGN, which was published in 2024. The 5 steps in managing asthma in primary care, incorporating AIR, that's Anti-Inflammatory Reliever, and MART, which is Maintenance and Reliever Therapy devices, Uncontrolled asthma and managing acute exacerbations, and the importance of considering future risk of exacerbations and when to refer to secondary care for specialist input. As usual, I've included links to resources mentioned during the episode in the show notes, and I say this every week, but just to give a little bit more detail, that list of links in the show notes is quite comprehensive. So, for example, in today's show notes, you'll find links to the college website, the College Respiratory Clinical Hub, a link to the last Asthma General Practice Quick Reference Guide written by Dermot Nolan and Des Murphy and published by the college in 2020, a link to the recent BTS, NICE and SIGN Joint Guideline on Asthma Management published in 2024, a link to the HSE Treat Your Respiratory Tract Infection Patient Information Leaflet, a link to the College Audit Toolkit, which includes an example of an asthma audit, as well as some other useful tools for use in practice, including a link to the asthma control test, asthma action plan, and asthma inhaler video techniques for patients from the Asthma Society of Ireland. So all those resources were mentioned by Paul over the course of these 2 episodes, and you can just click on each of those links as you listen in Spotify or in Apple Podcasts or wherever you get your podcasts, and it'll bring you direct to that website while you continue to listen to the podcast. So you'll find that not just for today's asthma episode, but for all of the episodes across the series, and hopefully you'll find that, a bit of a database of useful resources will build up over time for you and for your patients. And while you're there in the show notes, you'll also find chapter markers to help you navigate your way through the show. And again, I for one find these quite useful because obviously I listen to these episodes, but if I have something that comes up down the line and I recall that it was mentioned in a previous podcast episode, I can just go back to the episode, have a look through the chapter markers, and I'll know where to navigate to in the audio without having to listen to the entire thing again. And given that you are obviously listening to this episode, remember that all of these podcasts do qualify for PCS ePortfolio credits under the work-based learning header, and 1 hour of podcast listening equates to 1 credit. Okay, I think that's enough of an update for now. I'm going to move on to today's episode. Paul, thanks again for joining me today. We wrapped up last week with a focus on audit and practice improvement opportunities. Perhaps we could turn our attention now to management strategies. In the introduction there, I mentioned the recent joint guideline from the British Thoracic Society, NICE and SIGN. So perhaps you could start with an overview of that, please.
Yeah, so John, so basically in November 24, a NICE, SIGN and BTS, the British Thoracic Society, published a joint asthma guideline, which was very, very welcome in primary care. So it now recommends a single combination inhaled corticosteroid LABA combination. The LABA is it's formoterol, and it's from in people from the age of 12 years of age onwards, and for most patients with asthma. So what it is that you've got a reliever inhaler, which is your formoterol, that relaxes the airways, and it also treats the underlying inflammation at the same time, and that's the budesonide component of it. So formoterol is long-acting, but it's also rapid-acting, so it can be used for acute relief, like salbutamol, and then you've got your budesonide then to reduce, which is drip-fed. It reduces the inflammation within the airways. And I suppose there's two acronyms to be conscious of. You've got your AIR, AIR, and your MART. So you've got your AIR, which is your anti-inflammatory reliever, and that's I tell patients that it's, instead of using Ventolin, you use this dry powder inhaler, and it'll give you relief, and you just use it whenever you need it. You know that they mightn't have used the Ventolin that much. That's fine. You can use your anti-inflammatory reliever, and it'll open up your airways and dampen down any inflammation within your airways. And then you've got your maintenance and reliever therapy, and this is your MART, and this is where you use that same dry powder inhaler every day. So 2 puffs in 1 or 2 puffs in the morning and 1 or 2 puffs in the evening, and then you use a PRN then as required air inhaler then. So you tend to start patients on the air, so low dose as needed ICS formoterol combination inhaler, unless they're highly symptomatic, and if they're highly symptomatic, then you start them on low dose MART, which is your 1 to 2 puffs or 2 puffs in the morning, or else 1 puff twice daily. And then if they need any more than 8 puffs daily, you call me or you call out of hours. I want to listen to your lungs, make sure you don't have a pneumonia, but then, and we may need to up-titrate the treatment then. We may need to increase or add in another inhaler, or add in another tablet to your regimen.
So in essence then, your AIR, your anti-inflammatory reliever, that's as needed, whereas your MART is regular.
That's exactly it. Yeah.
Interesting for me to see as well, Paul, that there's a recommendation or a suggestion that you can use 2 puffs once a day, which I guess might have a benefit in terms of compliance as well.
Oh, absolutely, yeah. So and I suppose I always say to patients, they're used to 2 inhalers. So they say, so with this MART, is there a separate inhaler? I said, no. So it's the exact same inhaler, but instead of using it when required, you actually just use 2 puffs in the morning, or as 1 puff twice daily. A lot of patients will just use 2 puffs in the morning, and that'll be the best. So, and I suppose just to hammer home, that's the low dose MART. And then the moderate dose MART is 2 puffs twice daily plus PRN use. And then the extra doses then can be used to provide relief. So low dose MART, which is 2 puffs once daily plus PRN, or it's 1 puff twice daily plus PRN. And then moderate use then is 2 puffs twice daily plus PRN.
And then on from there, you've got 2 puffs twice a day, plus your as needed use. And if patients are still not adequately controlled in that regimen, where do we go from there?
Yeah, so I always say, look, if you need any more than 8 puffs, you're ringing me, you're coming in, make sure to listen to your lungs. But then you've got the step 3, I suppose. So with step 1, we'll say low dose MART, step 2, moderate dose MART, and step 3, MART, which is you'll be using 4 puffs daily, so 2 puffs a morning, 2 puffs at night. But then you'll be adding in either Montelukast, which is a tablet, or a tiotropium mist inhaler. So either one. So that's step 3. Step 4 then is your MART again, plus a trial of whichever one you didn't use. So if you use tiotropium mist inhaler step 3, then you use Montelukast, or it's vice versa. And then step 5 then is you use MART plus combined Montelukast plus tiotropium mist inhaler. So and that's it. That's it.
Okay. And the other point, I guess, with all of this is, if you are moving on to the dry powder inhaler, it's to let patients know that when they don't feel the spray hit the back of their throat, they should. And I know you're a big fan of spacer devices anyway, so they shouldn't really have that sensation if they're using a spacer anyway. But that they won't get that instant feedback telling them that the inhaler is going in.
Yeah, so there's 3 different types of dry powder inhalers on the market. I let them play with the 3 of them. I'll pick whichever one that they want, and whichever one they think they need, or whichever one that they think they like the most. And then I'll demonstrate how to use the dry powder inhaler. So much easier to use than we say the pressurized meter dose inhaler, so that for them to use that. But then always say, and write in the prescription, please demonstrate technique. I'd say to the pharmacist as well, and I say to the patient that get the pharmacist to show you as well. But yeah, absolutely, John. Yeah.
I might pop in a useful video from asthma.ie as well on that sometimes I'll send to patients via SMS, especially, for a bit tight for time. Some of these resources can be really useful. So that's the 5 steps in MART step-up therapy. But of course, it doesn't completely eradicate the possibility of an acute exacerbation.
Absolutely. So, and I suppose just to talk about acute exacerbations, the BTS and SIGN guidance in 2019 covered acute asthma management. And interestingly, the 2004 NICE guidance on the management of asthma does not cover the management of it. So first and foremost, acute asthma is mainly caused by viral infections, so they don't usually benefit from being given antibiotics. When the patient's in front of you, I suppose it's important to work out the difference between a moderate versus an acute severe exacerbation. So a moderate exacerbation versus an acute severe exacerbation. Moderate exacerbations, remember 75% is what I say. So at the peak flow, between 50 and 75% of their best peak flow are predicted and increasing symptoms. So if it's below 75%, if it's between 50 and 75%, it's a moderate exacerbation. Acute severe exacerbation, which you consider admission to hospital, remember 50%. So if it's below 50% of a peak flow, well then you're considering admission. So if between 33 and 50%, the patient has an inability to complete a sentence in one breath, respiratory rate of 25, and last criteria would be a heart rate of 110, but a lot of times they have lots of salbutamol on board, so it's hard to judge. But so I always say remember the 50% of the peak flow. The treatment, first of all, salbutamol pressurized meter dose inhaler via spacer, and then secondly, then prednisolone between 40 and 50 milligrams for at least 5 days. Okay, so just to talk about the salbutamol pressurized meter dose inhaler via spacer. So it's 1 puff every 60 seconds, and each puff should be given 1 at a time and inhaled separately using tidal breathing. And you give them up to 10 puffs if there's no improvement, and then you give 5 milligrams of salbutamol nib via oxygen. Okay, so just to talk about the prednisolone, so it's to make sure to give prednisolone because there's overwhelming evidence for benefit in exacerbations, but they're often underused. So counter to my mentioning earlier about the kids under 5 that we shouldn't be giving the steroids, in adults with acute exacerbations of asthma, we should. We know that steroids reduce admissions, relapse rates, and symptom duration in asthma exacerbations. Then obviously oxygen, and then admit any patient then with severe attack persisting after initial treatment. Those would be the most important points. So I suppose to work out whether a person has a moderate exacerbation or an acute severe exacerbation, and then you'll be getting the salbutamol pressurized meter dose inhaler via spacer, 1 puff every 60 seconds, and then oral prednisolone. Hopefully, when the patient improves, you're then going to work out whether it was a viral infection, whether they had good control of asthma and then a viral infection tipped them over, or else do they have terrible control and suddenly tipped over the edge because things have got worse or they've run out of their inhaler. So it's important to work that part out before they leave the surgery, No,
it's also interesting to hear you mention the spacer in adults, Paul, and I think there can be a culture in some quarters among some patients that they kind of graduated, in inverted commas, off their spacer when they went to secondary school and never looked back. And, the importance of drug delivery via the spacer is key, isn't it, in terms of effective therapeutic delivery?
Absolutely, yeah. So I always say that, look, a lot of times they'll have their inhaled corticosteroid at home by their bed, and I say have your spacer beside your bed as well. So we know that a pressurized meter dose inhaler and spacer, when you use the spacer, it doubles the deposition. okay, into their lung. That's the first thing. So I would usually, there's a different, you've got your free breath, your baby inhaler, and volumatic, and these are all on the GMS versus the air chamber that's actually not. I suppose just now that we're talking about spacers, make sure to clean the plastic spacers monthly. Interestingly, if you look at the instructions on the spacer, it says weekly, but it's monthly is fine. They should be replaced annually. Sometimes some of the patients, they may have the spacers a few years, and that ain't good either. And when you're cleaning them, you wash in detergent and rinse and then drip dry. You don't use a tea towel to dry the inside. So, and I suppose just to kind of go over, I always just to kind of go over a patient's, shake the inhaler and insert into spacer, press the inhaler once and breathe in and out slowly 5 times. So that's tidal breathing, and then only release 1 puff of medication at a time into the spacer. So I suppose that would be the kind of the take home messages with regard to spacer,
And of course, the cohort, Paul, who tend to have the spacers by default are kids. And maybe you could talk a little bit about acute exacerbations in the younger cohort.
With regard to acute exacerbation in children, John, again, you have to pick out the difference, to know the difference between a moderate asthma exacerbation and an acute severe asthma exacerbation. So, and I suppose just to go through the features of an acute severe asthma exacerbation, these are obviously the kids that are going to be going in for secondary care for treatment in the A&E. These are kids that have an inability to complete sentences in one breath, or they're too breathless to talk or to feed. They're using their accessory neck muscles. Their peak flow is between 33 and 50% of best or predicted. Whereas at the moderate exacerbate, those with the features of a moderate attack include those that are still talking in sentences. Their peak expiratory flow rates greater than 50% of best or predicted. And the treatment then inside in your practice, you'll be giving up to 10 puffs of salbutamol via spacer. So just like the adults, you'll be giving them 10 puffs. But in kids less than 3 years of age, you'll be using a face mask, and it's single puffs given one at a time, inhaled separately with 5 tidal breaths. So, and then just to remember about the high dose oral prednisolone. So this is for all children with features of a moderate attack. So, and it's a dose of 20 milligram once daily in children between 2 and 5 years of age, and 30 to 40 milligram once daily for kids over 5 years of age. So I know I spoke earlier about not giving oral steroids to those children who have a runny nose with wheeze. This is the opposite in this case. Now, John, it's very important that children with features of a moderate asthma attack get oral steroids. And I spoke about the overwhelming evidence for that to reduce hospitalizations.
And not only that, but in case people missed it, the dose is quite high, isn't it? In terms of the age, that you're talking about 30 to 40 milligrams of oral prednisolone.
Yeah, absolutely. Yeah, in kids over 5 years of age. So it is, and in adults you're talking 40 to 50 milligrams. So it's it is a high dose, all right. And I suppose the final thing then is to always consider future risk. So a history of an acute asthma attack is a major risk factor for future acute asthma. Salbutamol overuse is the other. Make sure to refer high-risk patients, because a history of multiple asthma attacks means poor control, means very high risk. And I suppose to always view an exacerbation, it should be seen as an opportunity to discuss self-management and an asthma action plan.
And of course, one of the benefits of the CDM program for those who are eligible is the creation of a little bit of time and space, maybe to go through appropriate asthma management from a variety of perspectives during that review, Paul.
So yes, John, at the asthma CDM review, so we check the symptoms, we check the amount of reliever used. I always say, going back to my max 2 Ventlins a year, no more than twice a week, no more than 4 puffs a week in that. And for them to, you could always verify with the patient, if they're unsure of the amount of Ventlins that they have in a year, you can contact the pharmacy, or they can contact the pharmacy for you. How many courses of oral steroids they had in the last year, I suppose, is another thing. Have they had any time off work or school, any admissions to hospital or A&E reviews? And you can consider a validated symptom questionnaire such as the asthma control test. So I suppose, what is uncontrolled asthma? So uncontrolled asthma is defined as any asthma exacerbation needing oral steroids or frequent regular symptoms. The patient with needing a reliever inhaler greater than 3 days a week, or, greater than one night a week of asthma causing nighttime awakening. And if it's uncontrolled before changes, so we'll just say the patient's in front of you and that they have uncontrolled asthma, so they're getting lots of oral steroids and that. So you think, is it adherence? Is it an alternative diagnosis? Do they have poor inhaler technique? Are they around smokers? Are they smoking themselves? Do they have any occupational exposure? So such as, do they work in baking or cleaning or healthcare work or chemical processing or spray painting, metalworking? You'd be interested. Sometimes it can be interesting to ask, to just clarify with the patient. They may have changed jobs. What are they now working as? But if there's any psychosocial issues as well going on. Make sure to always give them the action plan at the review. And in adults, the action plans should be based on symptoms. The peak flow is not used routinely in action plan unless the patient's poor at perceiving changes based on the symptoms alone. And that's as per NICE. Whereas in children, it's symptom-based plans are preferred in personalised action plans. And if you actually go to the final thing now, John, I know I'm taking a long time. Asthma.ie is a very good website that, for these action plans, be it the MART action plan or the regular action plan.
And aside from the asthma.ie piece, which I'm going to put a link to in the show notes, Paul, the other thing you mentioned that I'll put a link to is the asthma control test. It's really quick and simple, isn't it? And the patient gets a score. There's one questionnaire for adults, there's one questionnaire for kids, but it's very quick. And if you score on the low side, it suggests that the control is less than optimal, and it gives you a little bit of a starting point around optimizing. So I'll put all those things in the show notes, and thanks for that. And that CDM review really is a useful way, isn't it, these days to spend a bit more time and to really try and get on top of this condition. And with that in mind, Paul, before I let you go, have you any other take-home messages or pearls that you'd like to share with listeners?
I suppose back to basics. Be conscious of it with the patients who do have the four cardinal symptoms: the chest tightness, shortness of breath, the wheeze, and the cough. You need an objective test. Then you start, as per the guidelines in 2024, would they be suitable for the budesonide formoterol combination? There's a number of them available on the market, and go with whichever one the patient wants to use. And use up to 8 puffs daily is fine. If they're using any more than 8 puffs, give me a ring. But while they're waiting to see me, they can use up to 12 puffs daily. But I want to make sure to listen to your lungs, make sure you don't have any chest infection going on. That's it. John, I enjoyed that. I know it was a long podcast, but thank you very much for having me.
Many thanks again to Dr. Paul Ryan for speaking to me today. And don't forget to check the show notes for chapter markers and links to resources, as I said at the outset. Please feel free to get in touch by contacting us at podcast@icgp.ie if you'd like to provide feedback or input or suggestions for future episodes. Okay, that's it for today. Thanks again for listening, and until next week, take care.